Good day, everyone. Today, we are going to talk about bronchiectasis from its definition down to its prognosis. I hope you will learn something. Bronchiectasis is a chronic dilation of the bronchi and bronchioles that results from destruction of muscles and elastic connective tissue. This disease is more common in women than in men. Numerous factors can induce or contribute to the development of bronchiectasis. Some of these include recurrent respiratory infections, cystic fibrosis, rheumatic and other systemic diseases, primary ciliary dysfunction, tuberculosis, or immunodeficiency disorders.
Bronchi, which refers to the bronchi and bronchial airways of the lower lungs, and ectasis, which means a dilation or expansion. So in bronchiectasis, chronic inflammation causes the bronchi and bronchioles to get damaged and dilated. Bronchiectasis is an obstructive lung disease, and that's largely because the inflammation causes mucus plugs to form in the airways, and those mucus plugs obstruct airflow. Normally, when taking a breath, the diaphragm muscles move down and that creates negative pressure within the chest. This draws air in through the mouth or nose, and then down the trachea. Once there, it goes into one of the primary bronchi, or main bronchi, then secondary bronchi, or lobar bronchi, then tertiary bronchi, or segmental bronchi, and finally into the bronchioles, which lead into the alveoli. The alveoli, or just singular alveolus, is where the majority of gas exchange happens in the lungs. Taking a closer look at the airways, particularly the walls of the airways, they've got elastin fibers, which help give them their rubber band-like properties, and are lined with epithelial cells, some of which have brush-like projections called cilia on their surface, and others that secrete mucus. That mucus traps foreign particles, like bacteria and dust, and the mucus then gets swept upwards and out of the lungs by the cilia. Together, this whole system is called the mucociliary escalator. Eventually, that mucus and any stuck particles move into the esophagus, and then get swallowed and destroyed by acid in the stomach. Bronchiectasis results from diseases that cause chronic inflammation. One cause of chronic inflammation is primary ciliary dyskinesia, where cilia don't move normally and that leaves mucus stuck in the airways. Bacteria that's trapped in the mucus starts to multiply, and that can cause a pneumonia. If that happens repeatedly, it can cause chronic inflammation. Another example is cystic fibrosis, where the mucus itself is extra sticky and therefore hard to sweep. Once again, the mucus accumulates and recurrent pneumonias can lead to chronic inflammation. Another cause is airway obstruction, and that might be from a tumor growing within the airway or just outside the airway and sort of pinching it shut. Or it could also happen when a foreign object like a peanut accidentally gets lodged in a bronchiole. In any of these situations, the blockage prevents the mucociliary escalator from clearing out the mucus, and once again this leads to recurrent pneumonias and chronic inflammation. Also, certain types of infections like aspergillosis can worsen the problem because they can cause a hypersensitivity response which results in even more inflammation of the airways. So the reason that chronic inflammation is so problematic is that over time immune cells and their cytokines can actually damage the ciliated epithelial cells, as well as destroy the elastin fibers in the walls of the airway. Over time, the airways become dilated and clogged with mucus. Fibroblasts then move in to try to repair the damage by depositing collagen. The loss of elastin and the buildup of collagen makes the lungs less elastic and more stiff. The stiff, mucus-filled lungs make it tough for air to flow smoothly, leading to the pattern of obstructive lung disease. That inflammation can also extend to involve the pleura, which is the lining of the lung. And over time, as lung function declines, there can be hypoxia. To adapt to this situation, the pulmonary arterioles start to constrict, effectively diverting blood away from the most damaged areas of the lungs. But if the damage is widespread, then there's widespread vasoconstriction of pulmonary arterioles, and that increases pulmonary vascular resistance in general. When you increase resistance, you increase pressures, and in the lungs, this is called pulmonary hypertension, and that makes it hard for the right ventricle of the heart to pump out blood, and this can lead to right ventricular hypertrophy. And this whole process of right ventricular hypertrophy caused by a problem with the respiratory system is called cor pulmonale.
The signs of bronchiectasis includes finger clubbing, which is common because of respiratory insufficiency. Crackles and rhonchi are heard over involved lobes. Characteristic symptoms of bronchiectasis include persistent cough with production of purulent sputum. Many patients with this disease have hemoptysis, which is expectoration of blood of the respiratory tract. Dyspnea is also noted. Bronchitis is not readily diagnosed because the symptoms can be mistaken for those of chronic bronchitis. A definite sign is a prolonged history of productive chronic cough with sputum, consistently negative for tubercle bacilli. The diagnosis is established by a CT scan which reveals bronchial dilation. The advent of high-resolution CT scanning makes it possible to diagnose this disease during its earlier stage. Chest X-ray may reveal areas of atelectasis with widespread dilation of bronchi. Pulmonary function test evaluates airflow obstruction and impairment. Sputum examination may detect offending pathogens. Treatment objectives are to promote bronchial drainage, to clear excessive secretions from the affected portions of the lungs, and to prevent or control infection. Postural drainage is part of all treatment plans because draining of the bronchiectatic areas by gravity reduces. Chest physiotherapy, including percussion and postural drainage, is important in the management of secretions. Smoking cessation is important because smoking impairs bronchial drainage by paralyzing ciliary actions, increasing bronchial secretions, and causing inflammation of the mucous membranes, resulting in hyperplasia of the mucous glands. Drinking enough water can thin mucus, which makes it easier to clear out. Also, this prevents dryness in the nasal and airway passages. That is why it is important to stay hydrated. Treatment for bronchiectasis usually begins with antibiotics. Antibiotics are the cornerstone therapy for the management of a bronchiectatic exacerbation. Secretion management is an issue for patients with bronchiectasis. Bronchodilators, which may be prescribed for patients who also have reactive airway disease, may also assist with secretion management. In addition, nebulized mucolytics may help to clear airway secretions. Surgical intervention, although used infrequently, may be indicated for patients who continue to expectorate large amounts of sputum and have repeated bouts of pneumonia and hemoptysis despite adherence to treatment regimens. The disease must be involve only one or two areas of the lungs that can be removed without producing respiratory insufficiency. The goals of surgical treatment are to conserve normal pulmonary tissue and to avoid infectious complications. Diseased tissue is removed provided that postoperative lung function will be adequate. It may be necessary to remove a segment of a lobe through segmental resection, a lobe through lobectomy, or rarely an entire lung, which is pneumonectomy. The nursing diagnosis for bronchiectasis include ineffective airway clearance related to tenacious and copious secretions. Next is impaired gas exchange related to ventilation perfusion imbalance. Lastly is infective breathing pattern related to mucus and airway irritants. So for the nursing management, maintaining air clearance is observed by encouraging use of chest physical therapy techniques to empty the bronchi of accumulated secretions. Second, encourage increased intake of fluids to reduce viscosity of sputum and make expectoration easier. Lastly, consider vaporizer to provide humidification and keep secretions thin. So another nursing management is patient education and health maintenance. So it is performed by instructing the patient to avoid noxious fumes, dust, smoke, and other pulmonary irritants. Second, teach the patient to monitor sputum, report if change in quantity or character occurs. Third, instruct the patient and family about the importance of pulmonary drainage. Fourth, encourage regular dental care because copious sputum production may affect dentition. Lastly, emphasize the importance of influenza and pneumococcal immunizations and prompt treatment of respiratory infections. For the prognosis, it can be relatively good if physiotherapy is performed regularly and medications are followed. Thank you for watching this video. I hope you've learned something. Subscribe to this channel for more educational content related to medical surgical nursing. Have a good day.